Everyone, I can see a bunch of people calling in. Thanks for joining. We're going to give it several minutes. It's a few minutes to 4, but nice to see everybody again. Happy Wednesday. Hi, Holly. Nice to see you. Thanks for joining. How are you doing?
I'm great. Thanks for having me. How are you?
I'm doing well. Good to see you.
Me too. Me too.
I had someone call you this week. Hopefully they called you.
Who's that?
Bring your drink.
Oh,
Denise.
am I supposed to be drinking?
Yes.
Well, it's optional but encouraged.
Oh, please hold.
It is happy hour.
Is it?
Yes.
Please hold. Honey? Honey, I'm supposed to be drinking.
This is why it's good to join early. We know Rich was just finishing up a call anyway, so we'll give it another minute.
Ouch. Oh. I stopped my video. I didn't stop my sound. That was smart.
Beth is here. Hi, Beth.
Hi, Shelly. How are you?
I'm great. How are you?
I'm doing well. Long time no see.
I know. It's been too long.
It has. It has. I'm actually going to call you. Are you around tomorrow? I have a question for you.
Of course.
Okay. I was going to call you today, but I was like, I knew that you had this, and I was like,
Okay.
I'll call you tomorrow.
Anytime.
Have you had, it looks like you've got some sun. Have you been able to get out?
Today for me is HR at home at the shore.
Oh, yay.
Yes.
Which shore town?
I'm in Sea Isle.
Oh, nice.
Yeah.
Nice. My kids will be there. We're having, I guess our town has like Garnet Valley Week at Sea Isle, the end of July. So they're all, well, my
Nice.
daughter more than my son are planning to go.
It's nice. It's nice to be away and have some different four walls for a couple
Yeah.
days, you know?
Yes.
It's been interesting for sure just to see what it's been like to be away with social distancing and or not, depending on where you are. The beach has been, it's not, especially for the 4th of July week, it's not that crowded, particularly compared to other summers. I would say people are pretty respectful on the beach. Some restaurants, every other table outside, some no different. So it's been interesting to sort of observe that. But, you know, we're just getting dinner and we have 4 decks on the house and just having dinner here, and it's been nice.
Nice.
Yeah. All right. Well, our esteemed presenter was just wrapping up another call, so we'll give him a minute to just finish that up before he joined us.
Okay.
Thanks for joining, everybody. Good to see some new faces. And of course, those of you who joined before, welcome back.
Hi.
There he is. All right, let's go ahead and get started. Well, thanks everyone for joining week 10 of HR at Home. As I was saying, it's nice to see some new faces. And for those of you who are joining again, thanks for coming back for another session. We're glad to have you. As a reminder, our objectives are usually the same, which is to stay connected with the great HR community that we have here in Philadelphia. We are missing one of our objectives this week, which is to share legal updates because Keith is on vacation, so he will not be joining us. But of course, in usual fashion, we'll be sharing some best practices. And then of course, as it is happy hour, beverages are optional. So this week we have joining us Rich Krekstein, the Managing Director of NFP Corporate Benefits. Many of you may know Rich. Many of you may have NFP as one of your vendor partners. I want to share a personal story, which Rich is unprepared for, but I'm going to tell anyway. I've known Rich for a long time, several years. I have worked with Rich a couple of times through some clients of mine. And in particular, I will tell you, I'm giving away a little bit of a punchline. I've never hired Rich, not because I haven't tried, but Rich never fails to just give you really good advice. So when I got stuck a couple of times and just called him and said, what do I do? I'm stuck. I'm not really sure. Benefits is not a language I speak very fluidly. What do I do? He'll ask me really thought-provoking questions to make sure that I make the right decision. And doesn't expect anything in return. He wants you to do a good job and ask you really smart questions that you should be asking yourself, to ask your client or to ask your CEO. And in the last several months, I've spent time listening to some of the webinars that he has done on Mondays. He asked me to be a panelist. And then through a couple of my clients, I've been able to hear some of Rich's employees speak to my clients and talk about what they've been doing. To pay attention to COVID in particular, how it's impacting benefit costs for benefit plans. And in one client in particular that I have, how COVID has been impacting compliance. And I will tell you, and unfortunately this is recorded, so I can't take it back. Rich is one of the smartest people I know. And he has been doing just an amazing job, and so has his team. And over the last 2 weeks, I thought that what he has to share, and he has some pretty spectacular slides. And if you're a data geek, you're about to be blown out of the water. And so I'll let Rich share with you some of the stuff that NFP has been doing. And I think you're going to find this, time together really fascinating. And I think you're going to learn a ton. And so, Rich, I'll turn it over to you. And I think I'm going to stop sharing because I think you have some slides of your own that you're going to share with the group. So I'll turn it over to you, Rich.
Yeah, I'll tell you what's amazing, Shelly, is we've known each other for like 10 years, and that's like literally the first compliment you've ever given me.
That's not true.
So now I'm like, I don't know how I feel. I'm like, I'm going to cry. I'm going to, I'm waiting for the anvil to drop on my head. I'm not really sure where that came from. And by the way, there's a little cliff note there that Shelly is now a client twice because she was working with two of our clients.
That's true. You're right.
Help out on the HR side.
You're right.
So, okay, COVID, right? Let me get my screen share here. Can everybody see my screen?
Yeah.
Yes.
All right, it's not full screen though, right? Let me go full screen here.
No, it's not.
By the way, when I do my webinars, I get no feedback and it drives me crazy. So please, the more feedback, the better. Here we go. Does it look good now or no?
Yeah, it's pretty good.
Pretty good. Let's get it better. There we go. Okay. So real quick synopsis of how I became a COVID-19 subject matter expert. Back in March, when this thing hit, none of us really saw it coming. I mean, we were relating it to H1N1, SARS, MERS. We've been hearing about these pandemics for years. I've seen every movie there is. I was not expecting an outbreak to basically come to real life. So when this hit and we realized that, the world was really shutting down, I believe they canceled the NBA and Tom Hanks came down with COVID on the same night. Stock market went down. They called it a triple breaker, which means it was 15% pre-market trading down. So that was, I believe, March 20th was, as we knew it, the world was coming to an end. And unfortunately, for our jobs, this was extremely important because we had to actually, work through the cost implications of COVID. So not only was there family implications of COVID, not only was there a disaster that was basically hitting our country and our economy, but we had to then go to our clients with their health plans and say, what is the impact of this? And we had no idea. We were ill prepared for that. So we came up with this mantra, or I came up with this mantra. When navigating rough waters, a pessimist complains about the wind, optimist expects it to change. We adjust the sails. Really, I came up with this mantra, by the way, to try to incentivize my employees not to quit. So we were trying to, encourage them to kind of, keep their heads high and keep moving. But really, we adopted it and we started, monitoring COVID and monitoring the cost impact of COVID and understanding how we need to adapt what we're doing. So, quick observation. So, basically, during this process, we did what we always do, which is we look into data, right? So we looked at every study that was coming out of Wuhan. We looked at every CDC report, and we tried to ignore headlines. And when we read an article, we would just go down to the data points they were referring to in the article, and then we would fact check those and take our own observations. So a couple of quick observations on COVID. Number one, obviously, virus spreads very quickly and disproportionately. And I'll talk a little bit about disproportionately for a second. The first is super spreaders. So who on this call has heard about super spreaders? Right?
I have.
Everybody. Yep. That's the big buzzword. So oddly enough, and I do not have the science necessarily behind this, but oddly enough, they can trace back through contact tracing that 80% of all COVID infections come from 10% of the infected. So typically, if you look at, there's something called an R0 factor, which is the replication factor of a disease and how quickly it spreads. The R0 factor of something like measles is like close to 12, which means one person who contracts measles will give it to 12 other people. The R0 factor of COVID is not particularly high because it infects so many people, yet so many people don't necessarily give it to somebody else. A statistic that was released in a study in China, this is actually this interesting fact down here, only 16% of households gave an infection to somebody else. So if I got infected with COVID and came into my house, my household, person in my household only has a 16% chance of being infected. To me, that was a crazy statistic, right? Because if COVID is incredibly infectious in an indoor environment and I'm with my family, how is it not spreading indoors as frequently? So the theory around super spreaders is real. We just don't understand the science behind it. With that being said, we do understand prolonged indoor exposure with close proximity and recirculated air is how this spreads, right? Assisted living, correctional facilities, food processing plants are three of the main places in which this has spread and rapidly and done a devastating amount of damage, right? Correctional facilities in Ohio, this statistic's about a month old, but represented COVID infections where 20% of the statewide COVID infections were coming out of correctional facilities. In Pennsylvania, it's closer to 25%. But representing close to 70% of the fatalities are in nursing facilities or assisted living. So what we found on the employer side was these infections are very dangerous to a very small subset of the population that primarily does not reside on employee benefit plans. So we'll talk a little bit about what that population is and how serious the infection rates and illnesses are to that population. But what we found initially was that the cost of COVID, the actual cost to treat COVID, wasn't necessarily the biggest risk out there to a benefit plan. A couple other things, suppression works, but it's unsustainable. We all figured that out right around mid-April and in late May. Number of infections is much higher than reported. In the beginning of the testing, we were only testing people that were symptomatic. As you now know, and being widely reported upon, symptomatic infections make up anywhere from 10% of the overall population of infected individuals. So the CDC says that 35% of all infections are asymptomatic, but that number is expected to increase. And currently in the Florida infections that's going on, they were saying that up to 10x of the reported infection rate is the actual infection rate, because a lot of folks who are infected aren't actually getting tested. And again, the impact on healthcare costs is very difficult to quantify, but not impossible. And we're going to talk through that a little bit. By the way, if you want to interrupt me with questions, you can. You don't have to necessarily wait to the end. I tend to talk really fast. It's like drinking out of a fire hose sometimes. So does COVID-19 discriminate? If any of you have read recently, this is actually kind of a crazy statistic, but COVID-19 apparently does discriminate. Minorities are disproportionately affected by COVID, not just by infections and hospitalizations, but also by fatalities. So when looking at coronavirus cases per 10,000 people, this first exhibit you'll see in the upper left says by race, you'll see that Latino and African-American or Black populations are significantly higher than white infections, right? So now there's a lot of controversy being coming out of this statistic, right? So these statistics were actually gathered by the New York Times that used the Freedom of Information Act to sue the CDC to release race information. They didn't want to do it. And the reason is because obviously there's a lot of social unrest as it is right now, and they weren't really sure why these numbers are what they are, right? In the beginning of this, when we did one of our first presentations, we were talking about how somebody asked a question, how they see COVID affecting, you know, us being everybody. And I said that predominantly this looks like it's going to be an infection of the elderly and the poor, right? Simply due to the fact that, you know, socioeconomic, where you fall on the socioeconomic scale has a lot to do with your ability to A, suppress, B, what sort of job that you have and how you're interacting with people, and C, there's a lot of education and behavioral issues that condone themselves to spreading the infection. So, you know, this also has a lot to do with what you're reading right now in headlines when you hear about, you know, Florida and Texas. The problem is they talk about states when they talk about infections, and really what they should be doing is talking less about states and more about the counties inside of those states. So when you look at the increases that are going on right now, here you are looking at, this is on a per capita basis, which is a little bit better of a measurement because most of the measurements that you're hearing are cumulative. Cumulative numbers don't really mean anything, right? So it doesn't really matter how many people get COVID, right? What we're really looking is what percentage of a population is getting infected with COVID. Because if you go to a populous state, you know, with like Pennsylvania has 13 million people and we're producing 500 to 700 new infections a day, it's a statistically irrelevant number, right? And when they talk about the doubling, well, 500 doubles to 1,000, that's still a statistically irrelevant number of people. What you need to be more concerned about is what you're seeing in Florida, which is when on a per capita basis, which means the amount of people in the state compared to the amount of people being infected starts going through the roof. So here's just a breakdown of the different states and how they're being affected on a per capita basis. As you can see, right, with the exception of, you know, some of the hot spots that we'll call it, the infection rates are ticking up pretty much everywhere, right? Now, what I can tell you is this is a combination of A, increased testing, and B, lack of suppression, right? Once we were allowed out of our houses, obviously infection rates are going to increase. It's a no-brainer, right? I was actually a little bit surprised that, you know, how it was being perceived is like, of course the infection is going to increase. They were still increasing when we were sitting in our homes under stay-at-home orders. So, you know, it's impossible to live without this virus. We talk a little about fatalities. I try to stay away from fatalities, but there's a lot of talk right now about the fatality rates aren't rising in conjunction with the infection rates. That's true to some extent, right? But also remember, fatalities are a lagging indicator. It takes you, a typical incubation period of COVID is about 5.5 days, right? So it takes you about 5.5 days for the virus to incubate, a couple more days for symptoms, a couple more days for testing, a couple days for testing to be turned around. We consider that lag about 14 days. If somebody has a severe illness and reaction, typically they're going into the hospital, eventually the ICU, and if it's a fatality, you're looking at potentially, you know, 30 days lag from the point of infection, if not more. So I would say, you know, my only comment to that is fatalities are a lagging indicator whenever we're looking at infections. So we talked a little bit about comparing states, how states are having infection rises. And I think it's a little disproportionate to discuss a state as an entirety because every state is really its own little country. And if you'll look at these two exhibits, here are two different clients of ours, right? Two different clients, same number of members, vastly different impact depending upon when their members are, right? So an employer with employees that were in North Jersey and New York City versus an employer with employees in the middle of Pennsylvania are going to have very different likelihoods of cost impacts as in regards to COVID, right? So what we found here is that looking at states was meaningless. And what we really need to do was examine a county by county basis. I'm not going to go through this slide in too much detail, but just when understanding how you need to look at the risk for an employer plan, the first was we had to quantify it. So, you know, what is the risk of infection? If you do get infected, what is the risk of severe reaction to that infection? And then we had to quantify the cost. So what is the cost then of a severe infection? And what we found is that most of the cost relates to the same thing as pneumonia, which COVID really presents itself as the most likely disease. It turns into pneumonia, which is an infection of the lungs. So once we were able to do that, we had to determine what are all the cost drivers what were all the risk factors that drive somebody's propensity for a serious illness with COVID. And what we found is, number one, it was where you are. your geography. Number two, it was where you work as an employer. So somebody in a meat packing facility had a much higher risk than somebody who was home in a law firm. Second piece was demographics, age, right, was a big one, right? Third piece, employer health risk. So we had to determine health risk, underlying health conditions is a serious driver of your propensity to be hospitalized and or serious illness and infection or fatality from COVID, right? So what we had to do was take all those together to build out a model that said, here's how we know how likely it is that your employees will get infected. And if they do get infected, how likely it'll be that they will actually have serious illness as a cause of this. The third piece, and this is the trickiest part, were the hidden costs. So everybody in this call is in the Philadelphia area, I assume, somewhere around there, right? How many people went to a hospital in April? Right? Maybe a telehealth visit, right? But not many people were going into the hospital. And the reason for that is because the hospitals are really shut down. And if they weren't shut down, then you were still crazy to go into one in, 2 weeks into April. And for an employer health plan, this was a cost positive effect. We call this deferred services. So people were not getting health care, so the employer were not having to pay for those claims. Or if they were fully insured, the insurance carrier wasn't having to pay for those claims. Problem with that is reduced utilization, but at the same time, what we need to determine is how many of those services will be rescheduled. So, I hurt my shoulder, I would have gotten an MRI, but if COVID, the hospitals were locked down, I didn't go. It's better 2 months later, I don't need to get it fixed. Employer just saved money, right? On the flip side of that, I was supposed to go and get my well check or my colonoscopy. I didn't do it. 2 months later, I can do it. I still don't want to go. I'm not going to do it. That's called a gap in care, right? So what that could be is a claim bond that's sitting on my healthcare plan of deferred risk that's going to cost my employer or cost my health plan a lot of money down the road. Final piece, mental and behavioral healthcare costs. I talk to Michael about this all the time. I lost my mind for about 6 square weeks there. I have 3 kids under the age of 8. It was a rough go at it, and I consider myself to be pretty sane. So for those folks that were not able to do that, there will be mental and behavioral health care costs. What we've done is we've modeled out similar traumatic events, hurricanes, 9/11 was one. So we've modeled out a lot of traumatic events to look at the increase in mental health care claims after these events. And what we found is there will be a spike, but it's going to be a long, slow spike, and it's not going to occur for anywhere from 6 months after the pandemic is over to anywhere from 2 years. But a lot of substance abuse claims, a lot of depression, a lot of increased pharmaceuticals, we're expecting to see all of that. So when we talked about all of the spectrum of severities, you'll see the statistic, 80% of people that get COVID have a low to moderate response. The cost associated with that, that's just testing usually. Testing can vary depending on where you go. Now, a severe reaction, that's typically an inpatient stay. That's going into the hospital. Critical, that's ICU, that's a ventilator. Now, this was based upon a study that came out of Wuhan right in the beginning of this. And what we found is that healthcare systems are disproportionately placed and availability is disproportionate throughout the world, so that somebody getting hospitalization in Wuhan is not necessarily somebody getting hospitalization in the US. And what we actually found is the hospitalization rate was higher in the United States because we have a private payer system with more capacity, but our critical rate was much lower. So we talk about hospitalization by age band. Obviously, 65 plus was the highest risk category, 30%. The good news for employers is 65 plus did not necessarily reside on employee benefit plans. But at the same time, these are what you're reading about with assisted living facilities. You're reading about, with the elderly, that this disease is extremely dangerous the older you get. But it wasn't just based upon age, because what we found is that underlying health conditions were also a huge contributing factor. So ICU admissions, depending upon your age band, were anywhere from 3.5x all the way up to 5x. Now, all of these studies that we based this upon was during the period where the testing rate was only on symptomatic infections. So what we're finding out now is that when we lump in all of the asymptomatic infections, that these rates are actually going to go down. So we always had the numerator, we just never really have the denominator when we're trying to do this math. And unfortunately, we're never going to get to that point. So what we've had to do is adjust our model accordingly. The problem is that depending on how you adjust the model, also will adjust the total infection rate. So at first, when the COVID infection numbers were relatively low, we didn't think it was spreading as rampantly as it is. Now, if you said that there's 10x unreported infections, now this thing is a lot more widespread than we originally thought. So the chances and likelihood of getting infected would be higher. Just a little note on underlying health conditions. Just, you know, I don't know if there's any folks on this phone that have any or family that does. Just be careful. They're not all considered even, right? Obesity is a real driver and a real dangerous underlying health condition, but obesity is a wide range of the scale, right? You know, my BMI puts me as obese, but at the same time, there's a big difference between being clinically obese and being morbidly obese. And CDC is just reporting risk factors as obese. So on this slide, again, you can just see that, you know, the severity by age band is also connected to the severity of the health condition. So when putting together a cost impact model, what we did is we realized that it's not going to an employer and saying, here's what your cost of COVID would be. It's going to an employer and saying, depending on the time frame that you want to look at this will depend upon the cost of COVID, right? So COVID over a short period of time, depending upon your geography, may not cost you a lot of money, but over an extended period of time may. So what we actually did was create a model that, depending upon what the infection rate 7-day moving average is in that county where your employees reside on that particular day when we run the model, will determine what the cost is. Because we take that 7-day moving average and we take it and we trend it out to 30, 90, and 180 days. We factor in all of the different health conditions that that geography typically has. We then adjust it based upon the employer's risk. And we then add in what the age demographics are of the community, where those employees are, and what industry they're in. And we then calculate what the likelihood is, A, they will get infected, B, that they will end up with a serious reaction or serious illness as a result of the infection, and C, whether or not they will end up in an ICU. And those combined here, and what you'll see is when we do these numbers and we run them for employers, you get like a 0.56 ICU admission. And what that is basically saying is that we assign a dollar cost to every single employee based upon their likelihood of an event, right? So obviously, you know, there's no 0.5 people, but the only way to typically is to determine the actual cost or risk to an employer is to assign everybody a cost, regardless of whether or not their likelihood is high. So the lower likelihood of them somebody going to the ICU will have a lower associated cost.
And Rich, I don't know if your competitors offer this cost modeling, but I will tell you, just sitting with one of my clients whose plan year starts in January, and as people on the line know, you know, typically by August, September, you want to have your plan for next year done and locked in and rates confirmed. This is a really helpful, incredibly helpful conversation to be having with the CEO and a CFO, to be saying, we know if some of our employees have had COVID or they're covered beneficiaries, we know what the costing will be or has been or not, depending on whether or not they've been on the benefit plan. So we can prepare for what the rates will be for 2021. So it's a very impactful conversation to be having with the leadership team.
Yeah, we actually, so the 30-day number, we've been running this since, I'd say, early May, right? And our 30-day numbers were spot on. I mean, we were not far off. And the reason for that is because, again, every other modeling tool just used a ton of assumptions. We didn't use any assumptions. We used the actual data points and we just trended it out, right? Now, obviously 180 days, that's a crapshoot, right? Because you're one ICU visit away from just not being close. But on that 30-day number, I mean, we were really pretty accurate. And what we found is the reason we were accurate is because we did this on a county level. So we talk about what competitors were doing. In the beginning, most people were just checking a box, right? Because listen, we've been through this before. H1N1 was 60 million infections, relatively 1% cost to employers. It was like a non-event, right? So most brokers thought, you know, this is just going to be another exercise in futility. What we saw pretty quickly was not only is it not going to be one, but we wanted to create a tool that we really could hang our hat on, because our fear was from the beginning is that this doesn't go away, right? And we can talk about COVID and my views on it, but you know, I had said early summer when they went through yellow phase in Pennsylvania, I said, we'll go to green, but this is an eye of the hurricane sort of event, because as soon as people start interacting again, infection rates will rise. That's just, you know, that's like gravity, right? You know, it's just one of those things. Now, whether or not those infections turn out to be as severe as was first reported, you know, again, That's not something I'm necessarily going to, opine on. But, we saw this as being a moving cost impact that would need to be updated almost daily, depending upon the outbreak or the infection rate in that particular county. So this just models the actual cost of COVID, which from the beginning I said isn't a lot of money, right? The actual cost of COVID or care for COVID as it relates to an employer plan is not going to be that expensive. There'll be a huge human cost, right? But most of that human cost will be falling outside of a benefit plan for employers. With that being said, hidden costs, right? We talked about deferred claims. And this is something that we were saying from the beginning is going to be a win for employers, right? So what we're looking at here is non-catastrophic claims, right? And this is, by the way, we took we've done this a couple of times, and we just kind of take our hands and we take a big side swipe of employer data and we dump it into a bucket, and we produce these averages out of it. And they're pretty much spot on with the rest of our book of business. It varies a little bit by geography. It varies a little bit by industry, but by and large, these are the sort of decreases that we've seen. So again, right up until the end of the world here on March 21st, things were chugging along just like normal. Starting, March 28th is when things started to go down. At the peak of this, we saw up to 60% of a deferral rate, right? So we had estimated anywhere between 30 and 60. We got up to 60 of a deferred services rate. So what we saw, though, this was only on non-catastrophic medical, because when you look at catastrophic claims are heart attacks, lung transplants, acute high claimants. There really wasn't much of a change, because regardless of whether or not COVID was going on, these sort of, cancers and acute illnesses couldn't be avoided, right? So the third piece here that we saw was a pharmacy uptick, right? I mean, nobody could go to the doctor. Everybody wanted to stock up on their medications. Look at this on the first week right here on March 28th. Look at how high the pharmacy claims went up. Everybody ordered, right? They didn't know how long they were going to be home for, and they wanted to get their drugs. So the total, what we're seeing is about a 20% decrease in claims over a 14-week average, right? So when we looked at our employer populations and we said, all right, there's a 20% decrease. Now the trouble is, how do we attribute what's going to come back into the plan? So what we're seeing is a deferral rate of about, we said between 30 and 60%. So, right in the beginning of this thing. So in total, we're looking at about a 20% reduction in claims in totality. So when you look at 20% reduction in claims, the question is what percent of those claims will be rescheduled and what will not? And what we're thinking is that the majority of these claims will not be rescheduled. The majority of these claims are something that people postponed and are simply not going to go back and revisit. So what we're estimating is that how this is going to impact employer plans is a couple of percentage points of savings this year. We're seeing some of the best fully insured renewals we've ever presented to clients. Most of that has to do with how much money the insurance carriers made. Self-funding groups, we're looking at it and saying you're going to have a good year this year, and we're allotting a percentage of this based upon the types of claims that were deferred, to say that this is where the claims will come back. And they're going to come back in the fall, and they're going to come back in the winter, and they're going to come back in the spring of next year. And, by the end of the spring next year, there won't be any more in the system. At that point, everything will have processed through. The other thing that we're noticing is, depending on the type of claim, depends on whether or not it was deferred. Well visits, people are going to revisit and get their well visit. Imaging, trauma, not happening. Right? Nobody, nurses a bad shoulder for 4 months and then decides to go back and get themselves an MRI. So then there's another piece to this model, which is simply talking about the second wave in the fall and whether or not there's stay-at-home orders again, which could basically restart this entire paradigm. Questions?
Rich, a few seconds ago, your video froze, and we've had a lot of feedback since, and people are making comments. I'm not sure if you can hear it or not, or if anything changed on your end, but there's been a lot of static for the last minute or so.
You can't hear me?
Yeah, it's just a lot of static.
How about now?
Same. We put everyone on mute to see if it was someone else's line, but
I can call them here.
you froze up a second ago, and that's when it started. So maybe that will help if you just call in or something.
It's got to pop out of the video here. Can you hear me now?
Same. I'm assuming no one's hearing the crackling when I'm talking. Vicky, are you hearing it? No? Okay. It's you, Rich. We don't want to miss a word, Rich. We're hanging on every word. Thank you.
Can you hear me now?
There we go. Thank you.
Okay. I'd like to blame Shelley's Zoom setup because I never have a problem. I want everyone to know that.
I mean,
All right.
you know, you throw the guy a bone, see what happens. Okay.
I was going
thank
to
you.
say, Shelley, you did this after all the kind remarks in the beginning.
Thank you, Michael. Once again, this is recorded, so now everybody knows what happened. It's the truth. Thank you. Okay. No, thank you, Rich. Although you took your slides away, so.
Yeah, let me just share one last slide here, which is results will vary widely by geography. So what we're really seeing now is just, it is the wild, wild west from county to county and state to state. So what, you know, when we were all shut down, everybody was on the same page. It was all about the infection rates in that particular place. The infections were mostly in urban environments, obviously New York City being, you know, the biggest, the epicenter, but, you know, Pennsylvania numbers were being driven out of Reading, Scranton, and Allentown. Florida was primarily Miami-Dade, and the numbers were relatively stable. I mean, you saw in Louisiana, they had a huge uptick after Mardi Gras, and then it went down to next to nothing, right? Louisiana doesn't have a big urban population, or urban center, I should say, right? But what you're seeing now is that, you know, suppression fatigue, right? Everybody got tired. The social unrest, the protests, I know it's not politically correct to attribute any infections to the protests, but I mean, 100% the infection rates increased in certain areas due to protests. Now, they can't necessarily contact trace that, but you put that many groups of people together in an environment where they're screaming and shouting, and there will be infections, right, based upon how this spreads. So you take all that together, and plus you couple in, you know, the fact that most people were tired of COVID, right? They had really gotten tired of the whole conversation regarding COVID, and they didn't think the disease would really affect them. Right? And now what you're seeing are the repercussions of that. So the question is, where do you go from here? So, you know, a lot of what we're doing is trying to model out all the different scenarios to present, you know, high, low, and medium options to our clients. But the fact of the matter is, you really can't tell because it's all going to depend on geography to geography, right? If a state mandates masks be worn everywhere and puts social distancing measures and shuts down nightclubs and bars, you know, your infection rate will be very different from a state that doesn't do that. Questions, comments, concerns?
So, Rich, I have a question because some of the this is Beth.
Hi.
So,
Hi.
hi. And this might be a touchy subject, but it is a genuine curiosity. So you talk about the different measures that people can take. You know, the mask, the social distancing. You know, to open, reopen, too soon, too slow, whatever. Have you also kind of forward modeled depending on which candidate wins the presidential election? Because their policies have been stated very specifically, kind of like what happens as a result of the presidential election without advocating one candidate over the other, just kind of what happens.
Beth, there is no chance I'm taking the bait on this one. Absolutely not. I defer, right? There's no chance, right? There's too much going on in the world for me to weigh in right now. But listen, here's the deal, right? They did a study in South Korea, and if somebody, this was in SARS and MERS, if somebody wore a mask, they were 80% less likely to contract the virus, right? So 80% wearing a mask. Now, there's the problem is there's a science debate versus the the people that don't wear masks, right? So if you don't wear a mask in a country full of people wearing masks, there's a lot of other behaviors that you're going to exude that may cause you to get infected. Whether or not the actual mask will prevent you from being infected there's a scientific debate that they don't work, right? Right? There's an absolute scientific debate, but there's also a scientific debate that says they kind of work. They have to do better than nothing, right? So I think that if somebody asked me to weigh in on it, I would say wearing a mask qualitatively and quantitatively reduces the risk of infection. And I would just leave it at that.
Yeah. So I'm going to do a follow-up. It wasn't a debate on wearing masks or not wearing a mask. I know that when you model out what things are going to cost, have you done an overlay of the political environment and because you could argue if Trump wins, probably the costs will continue to be higher than if Biden wins because the policies will be different, or you've not done that overlay.
Well, unless one of them comes out with a policy that will be implemented well, by the way, the transition power doesn't have it in January anyway. So I don't think that listen, there's currently 413 vaccines in trials, right? There's several in phase 2/phase 3. You'll probably have an announcement on vaccines being utilized by late summer, early fall. The Chinese government literally, as a trial, gave a vaccine trial to their army, right? That's the trial, right? So I do think that there's going to be a much different vaccination conversation come October and September than there is right now.
Okay.
And but the question is going to be is how many vaccinations are going to be produced and how quickly and what's going to lead up to that is really what I can't answer.
Okay.
I think it's
Thanks, Rich.
you take the number of people wearing a MAGA hat minus the number of people wearing masks, multiply that times your distant relative on Facebook times 2.
It's not meant to be a political question. It's just a reality of the financial impact.
I think Michael's just trying to get me to weigh in.
I'm still trying to bait Rich.
Not happening.
Rich, are you seeing carriers? I mean, are you seeing any trends in the healthcare space from carriers as a result of COVID? I mean, obviously telehealth visits, but anything else on the forefront for 2021?
Well, I think the most interesting thing is, so part of healthcare reform is something called the MLR, which is minimum loss ratio, right? Which basically says if a carrier makes too much money in a small, fully insured market, they have to give some back, right? So the funny thing is all the carriers kind of were terrified because they made too much money this year, right? So literally they didn't pay claims for like 3 months, right? But they collected premium as if they were gonna. So what they've had to do is they've had to basically buy business currently renewing right now at almost a loss or give premium holidays going into the fall because they're deathly afraid they're gonna have to refund all this money to people. And then next year they're gonna take a loss on their rates. Yeah. So I've seen some of the best renewals, I mean, since I've been in the business, 15 years this year, right? Carriers are absolutely buying business in hopes that they'll offset how much money they made so they don't have to send big refund checks to everybody.
So what advice do you have? Sorry.
Oh, so I was just going to say, but also telehealth adoption's gone through the roof, but the problem is the carriers are reimbursing telehealth visits at primary care prices. Right. So it defeats the whole point of telehealth.
I mean, what advice do you have for people on the call as they're looking at renewals for next year then?
Simply, you have to be able to model out the cost of COVID on your plan and have that conversation, or else you can't actually negotiate the renewals. So like we have a new client where they had started at a 24 and they got down to a 7 and they were negotiating and they fired the old broker and they hired us, and I was like, 7, you deserve a negative 15, right? Absolutely. Because they stopped, they didn't incorporate any claims after February in the renewal calculation. So the carrier is playing a ton of games, right? Because they know that they literally had 4 of the most profitable months in their history. So other than that, I would just say you have to be able to understand the impact COVID is having on claims to properly negotiate any renewals.
What other questions do we have? There was a pre-question about mental health, Rich, and it doesn't look like the person who sent it in is still on the call. But the question about mental health was, do you see the future of mental health changing? I think you probably hit it around people, increased anxiety, et cetera. Like you talked about 9/11, for example. The person who's not on the call was going to ask to clarify, but I think increased prescriptions, perhaps anxiety and mental health care after being quarantined, and perhaps for a lot longer than we all originally anticipated.
So what was one, I don't know if I call it funny, but one interesting statistic that came out is that the telehealth claims were increasing on days when it was bad weather in the beginning of this thing back in April, right? So what that told me is not just telehealth for mental health, but telehealth in general. And what that told me is when people were sitting indoors and they were driving themselves crazy, they were having doctor visits. They were ringing up the telehealth, right? I think you're going to see the same thing on the mental health side, right? I think right now, mental health claims are probably through the floor because I don't think anyone's ever been happier, right? I forget the social injustice and unrest and all that piece. I'm talking about like for people that were their family life, what it was like to be locked inside for 2.5 months, to finally get out in summer and feel good and be outside in the fresh air. I think especially people with children, it's been a game changer, right? But what I think you're going to see is a huge uptick in mental health care claims and substance abuse claims coming into the fall. Because when we can't go outside and we can't, and by the way, school, I do think that school will be back. I do think that the economy can't survive without school. But I do think that school is going to be very different. I still get kind of disturbed when my kid has to go through a terrorist drill at school. But, where do you see the requirements and regiments that children have to go through to get back into school this year? I mean, it's going to be dramatic.
Yeah, I don't think a lot of people are over. I mean, I have friends who aren't, like, I'm at the shore this week. I have friends who think I'm crazy, and that's okay. Who aren't even social distancing in driveways with their neighbors. My one friend's husband works at a hospital, and he just refuses to interact with neighbors. He's extra careful, and his wife is, I mean, I think she's really struggling. In fact, I was talking to her yesterday and I just said, maybe it's time for you to talk to somebody. I mean, really, she's really struggling with, not having a regular life like we used to have. And so even though, I think I'm being careful and maybe others are too, I still think there are people who are struggling with going back to the way life was. I hate the word normal, but going back to the way life was. And I agree with Holly. I think mental health issues are at an all-time high right now. I really do think so. And I don't think, I know some folks' kids aren't going to go to college this year, aren't going to be able to go to school in a regular way, and so I think that's,
I would say that, I would agree that the issues that, mental health as the stress and strain and anxiety is at all-time high right now. But as far as how that's going to translate to claims, right, there's a delayed effect.
Yes,
right?
You're
and
right.
I think,
yes.
And that was my point talking about, telehealth being on rainy days, right?
Got it.
It takes a lot to get somebody to actually reach out for help.
You are correct. Yep.
So one other piece is, my wife jokes that like when I talk to a lot of these boards and I give a lot of these executive presentations to the executive teams and boards of companies, that like I end up getting into like personal conversations because somebody's like, my husband or my wife's out of their mind. Can you tell them that we can't get sick this way, or she doesn't need to lace all the grocery bags? And I'm like, listen, I'm not an epidemiologist. I can't get to that extent. But what I can tell you is what the statistics have told us. And what I can tell everybody on this call is that if you are under the age of 65 and you are healthy with no underlying conditions, right, that there is a very, very, very statistically almost irrelevant risk from COVID, right? With that being said, it's very scary and it's very dangerous. You may have an underlying health condition you don't know about, right? So, there's still high risk. Nobody should say they want to get this. That's the dumbest thing I ever heard. I don't want to get the flu, right? I don't want to get anything. But with that being said, you cannot, if you are not high risk, right? My advice to you would simply be live your life and be careful and be smart, but you can do more damage to yourself on the mental health side than you can on the physical health side.
Yeah, I think that's fair. Yeah.
Rich, I have another question. So based on the trends that you're seeing in the data that you delved so deeply in, what are some of the things that you think are going to affect us moving forward? I mean, we're going to get a vaccine, we're going to come out of this, we're going to have like a new normal, but what are the things that employers can be doing to prepare now based on what you think is going to be the future state, particularly around how it is with COVID?
Well, I mean, I've said kind of in the beginning of this that it's pretty interesting. Like, I don't think HR has ever been put on the forefront like they have with this, right? You guys have it from all angles, right? You got employee issues, you have compliance issues, you have healthcare insurance issues, right? You got virtual environment issues. Now you have like workplace safety issues. I mean, it's just remarkable. And then somehow everybody points at HR and they're like, you got this, right? Like you're in charge now of the no touch temperature check entering the building. Like, when did that become an HR issue? But I look at our own business, right? 6 months ago, we interviewed a candidate who wanted to work virtually and we wouldn't hire them. Like, weren't we jerks, right? I haven't been in my office in 6 months, right? I don't think we're probably going to be shut down for the remainder of this year. Like, we didn't hire this person because they wanted to work virtually. I have clients I've never actually met face to face now, right? Just on Zoom calls. So, what do I think are the, lasting impacts of this? I think they're going to be widespread. I think, we've all adopted in a new way in which we can function, right? We will have a pandemic-proof society, right? But I do think when you talk about like how you interact with employees, I do think, business travel, like things that we just took for granted were just normal. I don't think they're going to be the same. Like, why do I have to, drive to North Jersey to meet somebody when I can just hop on a Zoom call with 6 people and present the renewal report to them? Do they really need me to drive up there? Do they want me to drive up there anymore? So I do think that there's going to be a lot of lasting effects as it comes to that. I do think benefits, paper enrollment. I have a client that's been holding on to paper enrollment for years, and finally this pandemic broke them. And I was like, that's the one good thing that came out of COVID, is like you can no longer enroll your employees with paper. So I do think that everybody, HR especially, is just going to become extremely technology dependent in all aspects, whether it's onboarding, performance management, whatever.
Thanks, Beth. Other questions, thoughts, comments? We're getting a lot of comments in the chat feature about mental health.
Oh, I didn't see the chat feature.
People just making comments about mental health. It's impacting young people of all ages. Everyone has the right to choose to handle the virus any way they want. We need to respect everyone's choices. Employers need to be conscious, I think, to your point, Rich, about HR sort of needing to handle everything. And we didn't even talk about in this call about the diversity and racial injustice, which we have talked about in the past. That's also on HR's plate as well. Yeah, certainly HR.
I try to stay away from politics and social injustice topics as best I can. Those are.
It's interesting. We started
I will tell you, the COVID statistics around it, I thought were eye-popping.
Yeah.
Right. And I don't believe that there's going to be any science that's going to come out to support why that a person of color or minority should be any higher risk of infection than anybody else. It's simply going to be a socioeconomic.
When you looked at your last graph, I just found it interesting that the states that are resurging are border states. And I just wonder the rate of minorities in those border states compared to others. I don't know. I just wonder what those are. It's just an interesting statistic.
Again, the states are kind of, it's such a disingenuous fact, right? And that's why, by the way, here's my one piece to this. Be careful about headlines. Headlines are the worst, right? Coronavirus surging in Florida, ICU capacity being met, right? When you read into those articles, what you'll see is parts of Florida, coronavirus is surging, right? And parts of Florida have ICU and hospitalization capacity issues, right? But remember, that was the same headline that said that New York was going to be overrun in 3 weeks. And they built, an entire field hospital at the Javits Center that was never utilized, right? And I think because as quickly as the surge goes up, you can end the surge, right? It's very simple. You make everybody stay in their house, right? Like that's the one piece of this that we saw that was really apparent, which is suppression it works, and it works very quickly. right? The problem is A is the lagging indicator and B is all the political sensitivities around suppression. But when you look at Florida, what you're looking at is counties in Florida. When you look at Texas, what you're looking at is primarily Houston and some parts of Dallas, right? You're not looking at an entire state. And I think that's the biggest misnomer that you see out there. I mean, there's a lot of talk right now in Austin, the outbreak in Austin. Austin has one of the largest homeless populations in the entire world, right? And it is rampant among the homeless populations in Austin.
Yeah.
Right. So there's a big political conversation of why are you going to shut down, you know, the suburbs of Austin when it's the suburbs of Austin aren't the problem. Right. So it's a heated debate.
I mean, the same conversation was happening in Pittsburgh. I was in Pittsburgh in May, and something like 5% of the cases of people infected and dying in Pennsylvania, 5% were happening in Pittsburgh, and something like 75 or 70% of those were happening in nursing homes or assisted living. And so when I was out there, it was, why are you shutting down the cities when it was in nursing homes, right? And so, I mean, this is one of the reasons why I loved your Monday calls, Rich, is because to your point, you believe statistics, and I think you should go back to having your Monday calls. I know they're a lot of work, but your statistics are really interesting to listen to. Better than MSNBC and CNN and ABC, and because you're reporting people who are getting sick, and that's what is, those are the facts.
We took a break actually when the whole country reopened because there wasn't much news.
Yeah.
Right. And also what we were then doing was that was our, you know, our busy season for strategy reports. So every executive team out there wanted this presentation. So,
right.
But we're starting them back up not this coming Monday, but the Monday after that, because we're about to have a very interesting time again.
Yeah.
Because what you're about to see right now is what I'll say is the 60-mile-per-hour collision of pandemic, politics, and the economy.
Yep.
Right. And from an economic perspective, we cannot sustain another shutdown. Yeah. Right. Shutdowns were okay the first go around because everybody knew there'd be an end to them. Right. You do that to a lot of employers again, and you're going to have some serious damage done. Yes. Irreparable damage.
And a lot more unrest, which is, yeah.
Well, that's just kind of like the icing on the cake right now, right? Is that, you know, a pandemic wasn't enough, but then, you know, you throw in all the anger and social injustice out there, and now you're like, you know, and then murder hornets, they came in for a minute, right? Remember the articles on murder hornets? I mean, 2020 just doesn't stop.
Any other questions, comments? Well, before I forget, we are going to be doing every other Wednesday through the summer. So we'll be revisiting again in 2 weeks. And so you'll get another invitation or blast from our friends at Juno who do all of our advertising. So thanks to Juno for those. Rich, thank you. Appreciate it. I hope everyone learned a lot. I certainly did and always do. And really appreciate you being on and taking the time to do it. We appreciate it.
My pleasure. And I mean, it was purely worth everything for that compliment in the beginning. I just am going to go home and, you know, by go home, I mean, you know, leave my office and walk upstairs. But no, I can't thank you enough. It was a pleasure to be here. Great to see some old faces there. Or I should not say old faces. I'd say faces I haven't seen in a little while, Beth.
Very good.
Right. I got to, caught myself there. All right.
I got to go. I was going to save you. Thank you, everybody. Have a good week. Thank you.
Bye.